friends, today I'm going to talk about beta blockers. As you all know, beta blockers we use in the ward very widely, so you must know the commonly used beta blockers effect and the side effects, because we encounter so many problems regarding this beta blockers effect and the side effects inside the ward. So this learning is for life, not for the exam. Before I jump into the beta blockers, you must know where you can find the beta receptors. So beta receptors I have divided into three categories: beta 1, beta 2, beta 3. You just ignore the beta 3. This is beta 3 receptors found in the bladder. We use medicines beta 3 agonist against some kind of urge incontinence patients. So this is in very rare occasions you can see some questions regarding this. So our main target focus is beta 1 and beta 2. Beta 1 receptors are found in heart and the kidney. In the heart, it exerts an inotropic effect and increase the contractility. In the kidney, it increase the renin production. So in the beta 2 receptors are found in the lungs. In the lungs, it increase the diameter of the bronchioles, and beta 2 agonist we use for asthma patients. In blood vessels, beta 2 agonist can open the blood vessels. So in the blood vessels, if you give any beta 2 agonist in the blood vessels, there are beta 2 receptor. It open up the blood vessel. In the liver, as you all know, adrenaline is one of glucogenic hormone. It increase the glucogenic effect through the beta 2 receptors. Now we look at some commonly used beta blockers inside the ward, and the effects and side effect of those drugs. First, propranolol. Propranolol is the oldest beta blockers in the world. So it has effect on both beta 1 and beta 2 equally. So we used to say non-specific beta blockers. So it exert effects not only in the heart. When you use this medicine against hypertension, it reduces the hypertension by blocking beta 1 action in the heart. So it reduces the contractility, inotropic effect in the heart. At the same time, it can produce bronchoconstriction and the vasoconstriction. So it is contraindicated in asthma patients, and it can produce some cold extremities. So patients often complain when we start beta blockers with this cold extremity problem. So this is not only for propranolol. All the other beta blockers can produce this kind of side effects. Atenolol is more specific to beta 1, but it exerts some effect again in beta 2 receptors too. So it can even produce bronchospasm, and it is not wise to use in asthma patients. So don't use atenolol in asthma patients. At the same time, it can produce cold extremities as other beta blockers. So third medicine is metoprolol. Metoprolol is widely used inside the ward. It is found in injection form too. So you must remember this. Metoprolol we use in IV form in the emergency situations. So it according to book, literally they say that it has only beta 1 effect, but it has some beta 2 effects too. So it can produce some bronchoconstriction, and also patient come with cold extremities. And one important thing is metoprolol is very lipid soluble. Lipid soluble means it can cross the blood-brain barrier very fastly, so it can reach the brain too. So when it reaches the brain, it can produce some psychological side effects like depression. Patient can develop depression, or if a patient is already a psychiatric background, these patients depression can become more severe. In addition to that, it can produce some nightmares also. So if a patient complains with nightmares or depression or like symptoms, so avoid giving metoprolol. Instead, you can change the metoprolol to atenolol, because atenolol doesn't cross the blood-brain barrier. The new beta blockers is this is very new, bisoprolol. Bisoprolol we used to say here in England. It, according to book, it has only beta 1 effect. So it blocks only beta 1 receptors inside the heart. So it is a very specific drug. According to book, it doesn't exert any effect on beta 2 receptors. So it is safer to use even in asthma patients according to the book. So fourth one is carvedilol and labetalol. The difference between carvedilol and labetalol is very short acting, carvedilol is long acting. The specialty of these drugs are it block not only beta 1 but also alpha 1 receptors. So when it block the beta 1 receptors, it reduce the cardiac contractility, inotropic effect, and also when it block alpha 1 effect, then it produce vasodilation. So these are fantastic drugs against hypertension. Especially carvedilol is a very good drug against heart failure plus hypertension. So this is the drug of choice in those patients. We especially use carvedilol. There are a lot of research regarding carvedilol. So they are against heart failure. So this is one of a main drug we use in heart failure patients. So labetalol we use in emergency situations. If you want to reduce the blood pressure very quickly in emergency room, in the emergency tray, you can always see labetalol there. Labetalol is short acting, so it reduces the blood pressure very quickly and vanished from the blood very quickly. So that is the reason why we use labetalol, because it has not only beta 1 blocking effect but also alpha 1 effects too. So finally, the sotalol. Sotalol is a different kind of medicine. It has beta 1 blocking effect, but it has an anti-arrhythmic effect also. It functions as a type 3 anti-arrhythmic medicine. As you all know, this is the cardiac muscle action potential. This is calcium plateau stage. This is the repolarization. This repolarization can be prolonged if you administer sotalol. So it functions as a type 3 anti-arrhythmic drug like amiodarone. So amiodarone and sotalol fall into the same category. So we use this sotalol not only to reduce the we do use this sotalol only for anti-arrhythmic purpose. We don't use sotalol for as a anti-hypertensive medicine. We don't use, but we use it for as a anti-arrhythmic drug, especially patients with atrial fibrillation, in order to prevent the attacks of atrial fibrillation, especially patients with paroxysmal atrial fibrillation. So one important thing is this sotalol prescribed only by the cardiologist after the echocardiography, because we have to exclude any structural deformity in the heart before we administer sotalol. Otherwise, sotalol can produce serious ventricular fibrillation such as torsades pointis. So, and also we must take a ECG to find out the QT interval also before we administer sotalol. So sotalol should not be given by a GP. I have seen in my experience there are some GPs has prescribed sotalol, so never ever give sotalol before you become a cardiologist. Okay guys, thank you for watching. Good night.